Welcome everyone to the Clear Triage 10 for 10 speaker series. We are excited to have you all here today and especially excited to have Kathleen Martinez here. Um, and we will be talking today. The title of the conversation is Listening with Kindness, Building Trust and Accuracy in Triage Calls. So thank you all for joining. The webinar is being recorded. The recording will be posted on our website afterwards. For anyone who wasn't able to be here today, or if you want to share the recording with anyone. If you have any questions during the conversation, there's a Q&A button at the bottom of your screen. Please feel free to enter any questions in there and we will try to get to those at the end of our conversation. But I'd like to just go ahead and get started here. Kathleen is a past president of AAACN, as well as a certified evidence-based practice mentor. She has worked closely through the years with Dr. Barton Schmidt, the senior medical editor of the pediatric telephone triage protocols used in Clear Triage, and she's currently the clinical manager of the after-hours nurse triage line at Children's Hospital, Colorado. So Kathleen, I'm so excited to be talking with you today. Thank you for joining us. And I just want to start a little bit. I read that brief bio there that was on our website, but do you want to share a little bit more about your background and your experience with telephone triage, just to give people a sense of what you have done just before we get into the meat of our conversation?
Sure. Thanks, Dave. So I have been a pediatric nurse. I can't believe I'm saying this, for 40 years this year. And
Wow.
I know it's unbelievable, but the vast majority of my time, honestly, the most impactful time of my life has been the years I spent doing telephone triage. So I spent 15 years as a triage nurse, 6 years as a clinical coordinator, went out and did some other things. And then this last year was able to return to telephone triage as clinical manager. And it has just been beautiful to be back home to the work that really means the most to me.
Great. Well, I know that the call center there at Children's Hospital is happy to have you back. So our conversation today really sprung from a fascinating conversation you and I had at last year's AAACN conference. We were talking about listening, about spending time just listening to the caller beforehand, talking about families calling in and their experience, really bringing compassion and listening to the call. So that really sparked an interest in me in having this conversation, sharing with everyone, which really was one of the key elements to starting the whole speaker series here. So I appreciate your inspiring Krista and I to organize this. But let's jump in with a part of that. One of the things that you mentioned was you said when on the pediatric side, when a parent is calling in, that they're being brave as they're starting that conversation. Could you elaborate a little bit more on that?
Yeah, sure. I mean, even hearing you say that just, brings tears to my eyes. So, I work in a fair-sized call center. We cover many practices in a 7-state region. And we care for families after hours, like many of you listening, and on the weekends. And when a family picks up the phone to call, they're in a place in their life of anxiety or even crisis with a sick child. And when they pick up the phone, they're speaking to someone they've never met and don't know. And they are just inviting us into their home and inviting us to be a part of this experience that is highly emotional for them. And the bravery to reach out to somebody that they've never talked to before, create that bond of trust, and then share with us really what are very personal details, the questions we ask about how they've been caring for their child. So I am always deeply moved by the honor of being invited into this family's life to be a participant with them at this time in their world. I think about it sometimes because when I talk to my friends and they ask what I do, and I explain I work at after hours and we take calls for physicians, when the office is closed. Almost everybody I tell says, "Oh, I've talked to you guys and you were great. The nurse was so kind." And I think of it that in the tapestry of this family's life, this event that is causing them fear or anxiety or concern, we get to be there at that moment, and it's almost as if we are like a golden thread woven through the tapestry of that family's life, and they remember that connection, and they remember that they spoke to someone at a time of need, and that they were treated with honor and respect. So it kind of becomes a part of their heritage too. So
That no, that makes a lot of sense.
yeah,
How
and I
so go ahead.
was gonna say, sometimes I think when we do telephone triage and it's a 12-minute interaction, we don't understand the depth and the how important that time is. And that
Sure.
really lasts a long time.
So that makes sense. The trust, the bravery, the trust that the caller is putting into the call. How does the nurse reciprocate that and really start building that trust?
Yeah, it's interesting because like many things, the way we got involved kind of thinking about this is as any of you who are managers know, as a manager, often some of the interactions you have with families or with providers are when concerns or complaints come in. So we would get occasionally a concern or complaint would come in, and I would call the family to learn more about it. And it was never that the information shared was incorrect or that they were concerned that the advice was wrong. It was that the parent didn't feel listened to, or they didn't feel
Hmm.
like they were really respected during the call. So I stepped back from that a little bit and we started thinking about that. And that's when, after listening to calls, realized that what what a caller really needs and where we really build this amazing bond is at the front end of the call. As triage nurses, we have to collect a little bit of demographics and information. But the most meaningful thing is when we then say, so tell me what's going on. And then we do nothing but listen for the next 90 seconds. Don't interrupt, don't clarify, don't redirect. Just listen with a full presence. And at the end of that time, then move on with any clarifications and questions. Thank you for telling me that. Do you mind if I ask some more questions about the cough? And all of a sudden you have this, you can just sense it in the caller. They felt cared for, listened to, respected. They were allowed to share their thoughts. And it just sets the tone for a successful conversation.
And you mentioned saying thank you there. It seems like that's an important part of that in your mind, that thank you, that honoring the caller. Is that correct?
It's so important. I think about that a lot. Like, why wouldn't we say thank you? If you were having a conversation with somebody else, or you would ask somebody else for information, like the thank you just changes the whole tone. We've thought about, there are a lot of phrases that our nurses have, embraced and brought forward over the years. But one of the most meaningful ones I think that families need to hear is, hey, thanks for sharing that. You're doing a good job. I know this is
Mhm.
hard and you're doing a great job. And that can be dropped so easily into the conversation as you're maybe transitioning to some more specific questions or about to give some clear advice or direction on next steps. But you can just feel the parent relax. You can just feel this trust that develops through comments like that. And I'm always surprised that we don't use those more often.
No, I certainly appreciate that. You also said something that I find very interesting as far as when you've had complaints and problems, because um, here at Clear Triage, we wind up demoing our software quite a bit. And so we have people that are concerned about the legality. They're worried about a bad outcome. They're worried about a clinically bad outcome. But you said that is not really the common issue. The common issue when someone's having a problem is really that weren't feel they didn't feel that bond with the nurse. Can you talk a little bit more about that?
Yeah, yes. Well, if you think about it, so we do pediatric triage. So our nurses come to us with at least 3 years of experience in pediatrics, and they have, a pretty thorough training of 12 weeks to learn the skill of telephone triage. And the orientation, they're supported through that 12 weeks and then for that full year. And we have ongoing education, and we do have a reliable software tool that's evidence-based. So we have the tools to do the right thing clinically. But when you think about the environment where we are providing our care through telephone triage, and you think about communication, where it's commonly known that 93% of communication is the non-verbal, and only 7% is verbal, and we are left with just that 7% of verbal over the phone, we
Wow.
have to really think about pace, tone, how do we use pause? How do we create a safe environment? When I think about someone taking those 90 seconds to listen, which it turns out is based on evidence. At the time, we didn't realize it, but there are study that was done that shows that 90% of people don't speak more than 90 seconds before pausing for an interaction. And in my mind, that kind of aligns with the studies that have come out about when you're in a room with a patient sitting down at their level, how that changes the entire environment. When a healthcare provider sits down and makes eye contact, that's what we're doing in those 90 seconds of honoring the space and listening to the person without an interruption.
So let me push a little bit on that little
Yeah,
piece, because that's a very interesting one. And it's also one, if I think back to our conversation last year, that really struck me as something very different from what you typically hear. You've said that even a couple times in our conversation here, 90 seconds. What do you mean by that? What, in the context of someone calls in, and I'm sure that the nurse is starting with, okay, name of the patient, date of birth, you're identifying them, so on. Where does this 90 seconds fit in? And tell me a little bit more about your view on that evidence-based piece of that is listening that should happen there.
so of course, we don't have a stopwatch. It's not always 90 seconds. But it was creating the concept of non-interruption. So I still listen to quite a few calls with my team. It takes about a minute to get the basic demographics, verify name, birth date, practice, past history. And at about that 1 minute mark, the nurse takes a pause, because pauses are also really important. Takes a pause and says, "Thank you for sharing that. Tell me what's going on." And then with your fingers poised over your keyboard, you can be collecting the meaningful information that family is sharing with you. So the family, whoever the historian is, they kind of wind down about 80 to 100 seconds of kind of given most of the information that's necessary. And that's when we reflect back, thanks for sharing that. And then at that point, we can gather more specific information that we need.
So you said there was actually a study that showed that really it is around that time that people stop talking.
It is, it's so great. So you challenged me a little bit to say, where was that? Where did that information come from? And it is a study I'm happy to share where we found it, but it was performed in Switzerland. And they did a study, and the providers actually had a stopwatch when they walked through the room. So from the moment when they said to the patient, so tell me what's going on, they would hit the stopwatch. And they did that they had data for, it ended up, the final number was like 330 patients. So it was pretty impactful, and there were in-person interviews. But what's even more interesting is the way that this article started. It says that the average patient visiting a doctor in the United States gets 22 seconds for an initial comment before the provider takes over the conversation. So this is an incredible gift we're handing families to say, I am here and I trust you as a historian, and I'm going to sit and listen, because what you have to say has meaning and is going to really support providing the right care for your child.
Well, it's about that building trust that you talked about. I'm sure there are a number of people on this call are wondering, okay, so if we really go that route and we really are going to stop and tell our nurses to listen, we have metrics, we have number of calls we have to handle, things have to happen in our call center and with our patients. How does that listening impact the length of the triage calls?
Okay, so this is what's so crazy. It actually shortens the length of the triage call.
How?
Okay. Number one, you're allowing the family to give all the information. So think about this. Family picks up the phone and calls. Our call center is one where we call back. So now they're waiting for the call back. They're thinking, they're constructing their story. They're taking all the information that's been going on that they want to share with us. When they have an opportunity to share it from their perspective without interruption, it's much more thorough. The details are there. All the information necessary usually gets laid out beautifully in that first interaction. If we are interrupting or redirecting, then that family often, or the narrator often forgets what they're going to say, and important parts of the presentation can be lost. So
Or come up later on, and not in the natural flow of it. They're like, oh, I forgot to tell you this.
the famous, oh, by the ways,
Yes.
they are extremely destructive to call time and even to flow. And the other thing is, we often find by the time you've listened to that the initial information from the family and then filled in a few pieces, onset to, the basics, onset, severity, duration is covered, activity, hydration, pain, pretty quick. If they weren't covered, you cover those. At that point, you already have a picture of that child. I do, a picture of that child in my mind. I can picture the severity. Is this scary? Is my heart beating because this is a scary story? Is this a story where I can see this child comfortably sitting on the couch watching television? I have a sense of what's happening. And as I move into my guideline, it really helps me know where I'm focusing my energy and where I'm really going to get more information about the questions. But I'm also not spending time looking for things that aren't part of this particular situation. So I come in a more graceful space. Sure. And I can get through it more easily. And it does not add to time. And there are studies that show even in person, when providers take that time to listen in the front end, they don't end up having to pull it out of the person later. And, it flows more naturally.
Sure. And I would imagine, thinking of, I'm sure that most of the people on the call here are using the Schmidt-Thompson protocols. And because those are set up with the series of questions and the nurse's responsibility is to rule out each one until they get to the first positive question, I would imagine that also during that listening, you wind up gathering information that lets you rule out a number of those questions so you're not having to ask them, and it really, again, keeps that flow going.
So important. Never ask a question you already have the answer to, because then the family feels like you haven't been listening to them. So if a parent says to me, his fever was 101.2, or that, the last time they vomited, if in the story, they're like, the last time he threw up was 30 minutes ago. And then I get to the guideline and I'm asking, when did you last vomit? I've shown I'm not really listening. So you're right. You really gather that information initially and you already have that information.
Well, I would imagine that would be, that would break the trust that you're talking. It's so important to build if you do that.
It does. When you're listening to calls, you can hear sometimes I'm like, oh my gosh, why did they say that? Because the parent just told, I'm like, the parent just told you this. So, we have to use we have to be critically thinking. I mean, it's a hard job. You guys who do this job, this is such a hard job. And when you think about it, especially in a call center, you're getting a call from a family you've never met. You have no understanding of their history. In that first minute, you're doing a learning assessment. You're determining psychological safety. You're determining if this is a reliable historian. Are you getting the information you need? You're creating some kind of a understanding of their medical history and their background. And all of that is within the first 60 seconds. That you have to establish all of those things before you even roll into your assessment of what's going on at the time. So yeah, it's a challenging job that we have to do. And then to be listening, thinking, assessing, paying attention to all those elements while we're typing and then landing on the proper guideline to help move forward. There's a lot going on. So we all get better with time, but it's really a challenging, role, as you know.
Sure. I'm going to take a bit of a break from our conversation. I'm just looking at the Q&A on the side, and a couple people asked the same question, just if you can share that study. I think probably the easiest way to do that is if you send it to us here. As I mentioned, we'll post the recording of this on our blog site, and we can put the study in that, and that way everyone can have it. So we'll get that out to everyone that way.
It did take me, So I was really, like I said, when you challenged me, like, because I've mentioned it and I've used that quote, and then
Right.
you challenged me to find it. I was like,
Well, it's always, I mean,
God
we,
with
we
a
get those
bone.
things in our psyche that we've read and that we see, oh, I read this study about this, but then you come back a couple of years later and like, oh,
Yeah,
how do I find that?
yeah,
Luckily,
yeah,
we have this amazing thing called the internet that lets you
yeah.
find things.
It is
Oh,
amazing.
good. Okay, so we'll make sure to share that. Um, Back to what we're talking about. So I'm going back to, you said that people, um, and you're talking about parents, but I think that all of us understand that those who are serving adults or full age range, that it's the caller. It's just
Mhm.
that is the pediatric world that you live in. Um, so you say that people have complaints if they don't feel like the nurse is paying attention to them, is listening to them, and so on. As the clinical manager, what do you do if you have a nurse that is in that position? You know, how do you help coach them to be more compassionate, to be a better listener? What do you do in that situation?
There's a couple things. One thing that is very powerful is for many of you, I know calls recorded. What I've done occasionally is when a family calls me, or when I call a family back because there's been a complaint, I say, um, is it okay if I share this information with the nurse? And that I can record that call. And so I will always support my nurses and say, I I listened to this call. I know this nurse. She's a very caring person. I understand your frustrations with how the call went. And the parent will be, yeah, like I was sharing this and she just kept talking over me. And I say, I know that's not how she wants to come across. And I know she wants to do the right thing. And then that usually ends in a really nice, these always end in a very nice way. But then I can share with that nurse the conversation I just had with the family. And she can hear me support her, but then she can hear the family just saying their own words, how that
Well,
felt.
that's a nice combination.
Yeah. Yeah. It's important. And, you know, I've been learning, like many of you probably have, I've been really trying to learn more about trauma-informed care and thinking about how does that impact our world? And in telephone triage, honestly, at least in pediatrics, when we when we enter into the conversation from a place of grace and humility, like, thank you for calling me. Like, thank you for trusting me with your child, who is the most important thing in your life. When we enter the conversation that way, tends to stay there, but there are always times when people could be frustrated or there may be some frustrations. And workplace violence is a real thing. And a truly violent person on the phone who is degrading or using curse words or threatening in any way that is a terrible thing, and you need to hang up and get out of that conversation. But often families really come from a place where they just are frustrated, and learning that somebody being frustrated is okay, and speaking back to them words that are reassuring that you're listening and you want to make this better, you want to do what you can to make this situation better, often helps kind of diffuse that situation. So we're very fortunate. We don't run into many calls where there's any kind of escalation. And I think part of that is because of the thoughtful way we're approaching the conversations from the beginning.
Okay. So we've had, I mean, so much of our conversation so far has been around the skills of listening and compassion and respect. I'm going to shift us a little bit because, again, most of the people on this call are using the Schmidt-Thompson protocols. How do those protocols and this very rigorous set of questions and qualifications there, how do they mesh in with the compassion that you're talking about?
Well, you never read the question, right? The questions are not written to be read verbatim.
You don't read them literally verbatim,
Right,
right?
you're taking yourself into the experience of getting that information from the family. So I'm thinking about a call that we had recently. Child, had one of those face meets table
Ouch.
situations, lost a tooth, the mom couldn't find the tooth initially. So the nurse is asking, do you have the tooth? And mom's like, I don't know where the tooth is. So they're kind of working through that together. So asking the question, not saying, is the tooth present, just saying, do you have the tooth? Mom finally found the tooth and said to the nurse, thank you for being on this adventure with me. So kind of by making it your language. So when you're asking, when you're asking questions about the rash, like what was that, when you first talked to that family, what was your assessment of their level of understanding and their health literacy? So there may be a family where I can say, so how do I make it something that the family can understand and not be frustrated with me? So when they ask about a rash, is it purple? Does it look like a purple magic marker has little dots on the skin? Does it look like bruising? When you ask, if we're asking about retractions, like if you lift up a shirt and take a look at the chest, does it look like up by the collarbone, is the skin getting sucked in every time your baby takes a breath in? Like, how are we using the words? How are we getting the information we need from people by using the words that they can connect with? So I think that's health literacy, I think, is a big part of what we do, and how that aligns with the guidelines too. Like, and how do we, I'm thinking of some, like, is there any chance when we talk about, say there's vomiting without diarrhea, and one of the questions is, was there an ingestion? So how do you say to the family, is there any chance that your child got into any foods or medicines they're not supposed to be with in the last, few hours prior to the vomiting? So how do we make the questions really fit, as I tell my nurses, this patient at this time with this set of symptoms? So how do we make it meaningful when we're trying to get them information from them?
Right, because really what those questions are providing is they're a checklist for the nurse so that they don't miss something, but it is still the nurse having the interaction with the caller. And that list is there, not again, not to read through it, not to
Right.
be this harsh thing, but it is making sure, okay, I'm hitting all these things that maybe if you sat me down for an hour or two, I'd be able to do it. But I'm in the heat of this call with the caller, and I want to make sure that I am safely triaging the patient.
And again, don't ask a question you know the answer to. If it came
Yes.
out, if the parent told you this in the beginning, you know it. The other thing is I like to think of them as guardrails, not a checklist. Like some questions are not appropriate, and it takes you a while of getting through them to recognize based on age, based on other situations, based on something else with that family at that time or what's already been told. Some of those questions we know the answer to, like if the
Right.
child's, if you say, what's your child doing now before you even get into your guidelines? And they're like, well, they're outside jumping on a tram. You don't have to ask, are they unconscious? Or, you know the
Right.
answer
Are
to
they
that.
difficult to awaken? No,
Yeah, yeah, you know what's going on. So it's a lot of work. It's, it's, it's a lot of work. And I know we talk about, we only have 12 minutes. It used to be 9 when I started doing this. It was a little quicker. So we used to take about 9 minutes. And an interesting story is at the same time, about that time, because I was coaching nurses and saying, yes, 9 minutes of this focused. I'm only interested in you and your family at this moment conversation is deeply meaningful 9 minutes. So my son was injured in a hockey game and I had to take him to an emergency room. And we were there for 2.5 hours. And I kept track of all the time that somebody spoke to us. And in the 2.5 hours we were there was 9 minutes of conversation. And that just made me feel so confident coming back and saying to the nurses on our team, 9 minutes is a beautiful amount of time, or 12 minutes. Like if you're there and focus on that family, you are doing them a privilege. You have an opportunity to really get a good understanding of what's happening.
Sure. And just for clarification for the audience, when you talk about the 9 minutes or now the 12 minutes, is that complete time including wrap-up documentation, or is that time on the call with the caller?
12 is complete with wrap up.
Okay, so 12 is they're done and then they're on to the next call.
That's the average. Of course, our newer triagers take longer because again, learning that you don't have to. I just to be honest, the vomiting guideline has a lot of questions in it Like it
Sure.
takes a while to get good enough to know, like, these are questions that apply in this situation and these are some that don't. And to get that smooth flow where you've got a lot of the questions moving forward. So our newer triagers, it takes them longer to get to that 12-minute mark. It takes
And
them
it is average. I mean, there is that old adage, the sicker the quicker. If you have someone that's in an emergency
traumas.
situation,
Yeah,
that call is going to be very, very quick.
and it should be,
Right.
should be. They should
We
be
have
in
an
it now. Yep.
we have a couple interesting questions connected to this part that we're having right here. Is I don't know. You're my evidence-based person, so I'm going to throw this one your way. Is there any evidence-based studies indicating that calls should be around 12 minutes? They're just trying to gather metrics for their team, which is interesting to me because I've seen ranges all over the map in terms of length of calls.
Yeah, and I can tell you, so is there evidence? No. Right?
Mhm.
Who reports it? There's the best evidence, the best research is coming out of countries that have national health systems because they have much more access to things. So and there's a lot of stuff coming out of Scandinavian countries and Netherlands, New Zealand, Australia, where they kind of look at numbers, but nobody's really nailed it down. But I can tell you from listening, we do our 24-hour call review every other week. We listen to a call of, that somebody talked to that patient and the patient was not sent to ED. And within 24 hours, they got admitted and we want to see what's going on. I can tell you the longer the call, it is often a reflection that our nurse got lost somewhere along the way.
Hmm.
Somewhere along the way, they weren't pulling all those pieces together. And our very seasoned triagers can look at the constellation of symptoms and quickly see how things relate and have, they get through the guideline, but they do it much more efficiently while they're still compassionate and kind. So I think as you listen to calls as managers, see what you think. When the nurse is kind of just asking the questions, ask the questions versus it, her initial differential of risk and urgency for the symptom. How is she really bringing that information in? So be great if there was a standard, but it's different by age, it's different by diagnosis, it's different if it's in an office and you're a care coordinator who also does telephone triage and you have responsibilities for appointments or refills or things versus an after hour when you're really just focusing on the symptoms and giving advice on next steps.
We're getting close to the end of our time. There's a question I want to touch on here. It's kind of connected to that. So you talked about so the question is, do you have any standard call evaluation form for your nurses? How you're evaluating your nurses, but I also do want to make sure, because I always find it very interesting with Children's Hospital Colorado, just if you could lay out again how you pick those particular calls, because I think a lot of people do call reviews, but it's kind of which calls do I review? And I think you have a very interesting selection of that. So I'm throwing out two different pieces: how you
Yeah.
select your 24-hour call review, and then also the call evaluation form.
So a couple things. So we really do many different types of call reviews, probably 8 or 10 different types of call review. And I want to say too, I did telephone triage for like 20 years before 2020 and left, and coming back to this very remote world has been complicated and it's harder, I do believe, to kind of keep tabs on what's happening with all of your triages potentially. So we do have a focused way. How do we get the best bang for a buck rather than picking random calls to evaluate? How do we focus it? So one thing we do, we work with our quality improvement person. We identify a high risk or a concern that's come up. And then we listen to a certain number of calls for all of the nurses for the same guideline or the same chief complaint. So then we're getting a good sense of what's happening across the whole department. Is this an area where we need education, training? Does a guideline need to be evaluated? Where are we failing here? Where's the risk? How do we mitigate the risk of this particular call? The 24-hour call review is kind of my favorite because we're like, there's no harm. The patient's fine, but we are proactively saying, where is something where maybe we could have done things a little differently? In pediatrics, often it's the reason the child wasn't sent in is because it's progression of illness. Call, they're kind of croupy, we do a treatment, they're doing better, the nurse tells them very appropriately, call back or go in if this happens. Then the family follows that advice, goes in very appropriately. The ones we're concerned about is that somehow during that assessment, the nurse either didn't pick up on a symptom or didn't assess that symptom fully enough to get to the level of care that they need to get to. We also bring that back for education for that person and for the team. And we've recently started putting best practice reminders in our daily huddle. We change them about every 2 weeks based on findings from these 24-hour call reviews.
Okay. We have one person that asked about sharing this interview with their internal triage team, and yes, connected to what I said before, we will post this in the blog. On our blog, everyone who is registered for the webinar will get a link to that, so you'll be able to share the interview with anyone you want. Another person asked they were curious about your thoughts on when a nurse has consistently low average time managing calls.
When their call times are super short,
I think
time?
this is a question from Chris. You can add more to it, but I read it as, yes, their calls are low.
Well, that could be just as serious, right? So it's really not the call time itself. What we consider nursing sensitive indicators is assessment complete, correct guideline, correct disposition. So if you go in and listen to that person's call, you will know pretty quickly if their assessment is complete or not. So if they're not asking the questions necessary for you to agree that that patient's getting to the right level of care, then that's a performance issue and they need to be on a plan. Now,
Okay.
if they are just super amazing and every time get a trauma call and they are done with their calls in 7.5 minutes, that's different. But it's really your assessment. That's why we have to listen to so many calls to really know what's going on. And we have to look for the problem calls, which are the folk who, and I could talk triage all day, as you know, Dave, so I have to be very careful. But if there's somebody where we have concerns, we do our whole leadership team of 5 people. If one of our associate clinical managers have concerns about one of their people, we do what's called a 10-call review. We pick the problem area, like maybe newborns or long calls, and our QI person pulls 10 calls. We each review 2, and then we get together so that we're sharing all of our insight and knowledge to be like, whoa, this person really is struggling with this. This is where they need some coaching or mentoring, or this is a problem. We need to now talk about a performance plan, remediation, follow-up. So we have pretty structured ways of addressing that.
Let me take one last question that we have here before we wrap up. This person asked, do you have any recommended training for call control techniques for phone triage nurses?
I think actually one of your articles was one of the best we've read that Kelly Massaro wrote on how to kind of help things moving forward. So if we can find that, post that.
The Schmidt-Thompson newsletter that Kelly wrote.
That's really,
okay.
really good. But the
Sure.
other thing is, this is where, I don't know about your nurses, it's where my nurses run into trouble. They do a great job. We get to the end, they give the disposition, this is hard for people, just the 2 to 3 parts of care advice that really apply to that patient at that time, with that family, with those symptoms, not 12 pages. Here's the hard part. Thanks. Oh, thank you. Let me know if you have any other questions. Okay, thank you. Thanks for calling. Okay, well, all right. So we kind of joke that if we could just cut those last 15, 30 seconds off the call and help. So that efficiency too, is like, when you're done, be done. Like, you got
and
to
have your pattern of this is how I wrap up the call.
Yep, be ready to move.
Yeah.
So
I lied. There's one very short question.
Okay.
Who is your QI person? A nurse champion, a supervisor?
It's one of our nurses, or one of our very qualified and experienced nurses. She does our technology and our QI, and she helps kind of coordinate it. But all of our leadership team, a big part of our job is doing QI. We have a small committee that also helps with some, but the bottom line is it really is entrusted to All of us as managers have to be experts too, and have to be able to do, because then we do the hard work of working with our team members for either performance, mentoring, coaching, whatever is necessary. So our QI person is a nurse who actually takes calls for part of the role too.
Well, I
And our
appreciate the
ACMs,
jump in.
I'll take calls too. We all take calls.
Who takes, you said you're,
Associate clinical managers, when they're charged, they take calls, and then I still take calls
good. Yeah.
occasionally. It's good
Well, good.
reminder.
So I appreciate the jump into QI because I know that's another passion of yours, but I'm going to come back and just, is there anything you'd like to say to wrap up the first part of our conversation around listening and compassion and respecting the caller?
No, I think when we start the conversation from that place of awe that someone has reached out in a crisis moment of their life and trust you to guide them through this, I think that brings that level of respect and compassion that sets up a really positive interaction. And, you know, at the end of the conversation is that's when that sincere gratitude comes back from the family. And as much as we talk about compassion fatigue, there's actually a stronger force called compassion satisfaction. And if that is that interaction we have the privilege of to have with families and patients, where we respond compassionately to them and they respond with gratitude. And that's what keeps us in the field. That's what keeps us doing what we do.
I love that as a closing thought. Kathleen, thank you so much for joining me today for this conversation. Thank you for everyone who's been listening to this conversation. And please the link will go out. Feel free to share it with anyone that you think could benefit from listening to this. I hope you all sign up for some of our future conversations as well. Our next webinar we're taking a different tact. It is an interesting webinar with Cecilio Murillo, who is the System Vice President with Common Spirit. And he's helped build a system for any of you that are in a situation where you have multiple EMRs in your organization. He's really helped drive a technology where they're using Salesforce to span a number of Epic and Cerner instances, so their nurses don't have to jump in and out of different EMRs, but their nurses and call center staff can work in a singular system above all of that. So I think that'll be a great conversation. But again, thank you all. We have the QA. I think we've answered all the different questions except for one person asked if you could share your QI form. If you're able to do that, Kathleen, we can post on the blog. Thank you all for your time today. We really do appreciate it.
Thank you.